Welcome. My name is Paul Krack, and I'm sitting here presently at the Convention Center in Stockholm, where presently the 18th meeting of the MDS is taking part, Movement Disorder Society, which has been called now the Parkinson's Disease and Movement Disorder Society. We are on June 9th in 2014. I've been asked to interview Professor Pierre Pollack so that members of the Movement Disorder Society can get some insight into his professional career. So, Professor Pierre Pollack, you are well known to the field of movement disorders, to the people working in that field, especially because you have been very influential in developing deep brain stimulation, DBS, which has become treatment of Parkinson's disease, other movement disorders, but which is also a tool to study pathophysiology. All this work you did, this pioneering work you did it together in very close collaboration with Professor Benabid in a small city, somewhere in the middle of nowhere in the French Alps, which is called Grenoble.
No, it's famous. Sorry to interrupt you. It's very famous. The Olympic Games in 1968 took place in Grenoble.
I was not born.
It's more famous than the neurosciences, of course, but it's not such a small town.
Okay, I was not born then. Sorry. Okay, and you also have received the Stanley Farn lecture. You have been awarded the Stanley Farn lecture. That was back in 2007 in, at the MDS meeting in Istanbul.
Yes.
So I would like to probe a little bit to your early life. Would you be willing to tell us about your personal life, personal background, early educational years?
Early, before medical school?
Before I was born.
Oh. So I was very interested in sports, in music, but also in how brain functions. And so during my education, I have no part which was better than another. And when, just after what we call in France baccalaureate, we have to choose the type of studies. And it was very, very difficult for me. Perhaps I prefer to become a pianist, but I was not very gifted. And I would say perhaps I will be a teacher in the conservatory. And the other possibility was to become a doctor, a medical doctor, because I think that to become a medical doctor, you should be interested in humanities, but also in mathematics, physics, biophysics, and in many fields. And as I was in the medium in everything, yes, I decided to go to medicine. And my father, as you know, my father was a general practitioner. My uncle was also orthopedist. So I decided, but at that time, I think when I was 17, I preferred to become a cycle champion.
Yes.
Or a pianist.
to get over the Alps with the bicycle. But I remember there was not only doctors in the family. I think the family was very fond of music.
Yes, fond of music. You know, my father came in France to study medicine. Yes. It was not possible. I was from a Jewish ancestry in Central Europe, and it was not possible for them to go to the university. And that's why he came to France and become a GP and remain to France and in Grenoble because of the resistance.
And he brought the culture of the music.
Yes, and in all these type of Central Europe families, everybody plays music, and there is chamber music only with the members of the family.
Yes, that's why you like that very much. Okay. And how did you then, once you had did this choice to go to medicine. How did you come into neurology, then movement disorders, science?
Oh. As I told you, I was very interested about how the brain works.
Yes.
Was mainly interested in memory, cognition, behavior, and it was a total mystery at that time. And I hesitated with psychiatry, but really for psychiatry, we understood absolutely nothing how the brain works. So I prefer to choose neurology, and the other major fact to choose neurology was Professor Pierre, one of the mentors. He was the head of the neurology in the Grenoble University at the time, and I had an excellent contact with him, and he proposed me to stay in neurology. And of course, I would say that working in the brain was my choice. Perhaps for also surgeon, because I like to play with my fingers as a pianist. And but neurosurgery at that time was too difficult. We had in the emergency room for 1 week long. Imagine 7 nights, consecutive nights in the hospital. So I could not stay far from my piano longer than 2 days.
It was not only on call, it was being in the hospital?
Yes.
Horrible.
So you know now why I chose neurology.
Okay, and from neurology, what influenced your choice in movement disorders? Did you have mentors?
Yes, it's a long history why I decided to study Parkinson's disease and movement disorders. Claude Feuerstein was at that time, he was about the same age as myself. He was in physiology and pharmacology, and he worked with Ivagid in Paris for blood sampling and measuring the concentration of catecholamines at that time. It was not done in Paris, curiously. And so we had contact between the Paris group, Ivagid, and the Grenoble group for these catecholamine measurements. And Claude Feuerstein did a study on the relationship between L-DOPA and other catecholamines, concentration in the blood, and the clinical status of the patients during an acute levodopa challenge. But the clinical examination of the patients was not right, because it was not permanent, and as you know, patients with fluctuations with this short duration response to levodopa can change from minute to minutes. So I decided to study these fluctuating Parkinsonian patients, but staying by the side of the patients for 3 or 4 hours for the duration of the levodopa test, and measuring every 10 or 15 minutes, I think, blood concentrations. So this was my first contact with Parkinson's disease and movement disorders.
Measuring the concentration and looking at the patient at the same time, so
yes.
Correlation.
And I think that minutiously looking at the patients, at one patient for 4 hours, it was the best teaching I ever had. It's better to well know one patient for 4 hours, one fluctuating patient for 4 hours, than tens of patients for 20 minutes.
That has become kind of a philosophy almost. It's different approach from the modern approach of evidence-based medicine.
Yes, I think that all I have discovered in neurology was a teaching from the patients.
They taught
the
you.
Patients tells you, and if you have some insight into the pathophysiology, you understand. But you have to carefully listen your patients.
You have to have the eye into this. Okay. And how did you have mentor? Who
So,
helped you?
after my medical thesis, I went to Paris.
And the medical thesis was about?
On this study, on the correlation between L-DOPA and catecholamine blood concentrations and motor function in fluctuating Parkinson patients. So it was by the end of my internship, resident, and then I went to Paris to study neuropharmacology and to have in-depth studies and research project in Ajit's group.
While still being an intern?
Yes, I was.
Okay.
I was a resident, but it was possible. I have time to make some clinical research.
Okay.
So I stayed in Paris. The head was François Lermite, and there was also a famous professor in neuropsychology, Signoret, called Signoret. And Yves Agid was the assistant at that time. But he was still famous because he had discovered the fact that the remaining dopaminergic cells were active. And this was, I think it was published in one of the best in Nature or Science at that time, when he was at the Collège de France. And he just came back to the clinics.
And that was at the Glowinski School?
Yes, he was in Glowinski, in Collège de France, and after he came back to La Salpêtrière. So I was at La Salpêtrière, and I think Yves Agid was really my mentor. He taught me everything, how to look at patients, to examine patients in depth with Lermite and Signoret, how to propose scientific projects, how to carry out this project, and how to write a paper. And the project I was involved in when I was in Paris was domperidone, the action of domperidone, this anti-emetic drug. And it was the objective was to demonstrate that domperidone enabled the bromocriptine increase without side effects. And it was incredible. We increased bromocriptine by 10 milligrams every day. So and so the results was very clear.
You went up to?
To 150 milligrams in some patients.
Bromocriptine per day?
And the patients who tolerate the best bromocriptine was in the placebo group. So despite this was clearly demonstrated the interest of domperidone in avoiding peripheral side effects induced by dopamine agonist drugs.
So that was your first scientific work in neuropharmacology?
Yes.
Published?
Yes, it was published in the Lancet.
Lancet as an intern?
Yes.
Okay.
So I began to be slightly more competent in neuropharmacology. And when I came back to Grenoble, I continued in neuropharmacology. And so just after my stay in Paris, it was in '78, I had a stay in North America for 3 months only. I visited 3 groups, but I stayed for 2 or 3 months with André Barbeau. And André Barbeau, I would not say he was a mentor, because I stayed for a short period in his lab, but he impressed me so much, because he had this interest in pathophysiology, like Yves Agid, exactly. When he examined a patient for any sign he is reasoning was how the brain works and to induce such symptom. At the time he worked a lot on ataxia, and then especially Friedreich ataxia and other family ataxia. And I remember that he told me, oh, Pierre, do you know what it is? And he wrote a mitochondria.
Okay.
And I say, yes, it's a mitochondria. Everything and the reason for Friedreich's ataxia is here. It was many years before the discovery of the frataxin. And we know now
So
that
today we know.
there was a defect in the energy process in this disease. So because of peripheral measurement, it was excellent also in pharmacology and to measure metabolites. And he understood that the one of the major problems in Friedreich's ataxia was the energy in cell which was defective.
So eventually you developed new pharmacology in Grenoble.
Yes.
I remember having seen some early papers on apomorphine.
Yes, apomorphine. Yes, it was in the 1981. I wrote 1 or 2 papers on apomorphine, but I used apomorphine as a dopamine agonist, like a levodopa challenge, but it was shorter. It was you had to stay with the patients for 1 hour and not 4 hours.
Okay,
So it was it was time saving. And I knew from the domperidone study, I knew that it was possible to use apomorphine without inducing vomiting.
It became a usable drug.
Before 1980, apomorphine was used only to induce emesis and not as a dopamine agonist. So, and the laboratory which made apomorphine was in Lyon, very close to Grenoble. So I worked with this laboratory to get apomorphine, and I made a lot of tests with apomorphine. And in 1987, in parallel with Androlise in London, I began to use what was given by the diabetes, the Penject and the mini pumps. And it was the beginning of apomorphine. But I didn't give a lot of energy in neuropharmacology and in apomorphine, because exactly at the same year, in 1987, there was the discovery of DBS.
Okay, so you did not have the time to go further. So
and in parallel also my position moved from neuropharmacology to neurology.
Okay.
Because in 1987, the position in Grenoble for myself was in neuropharmacology, and there was many events, and eventually was said, no, you will be better in neurology and not neuropharmacology. That's why I gave up pharmacological studies.
How did you come to work with Professor Benabid in Grenoble?
Also a long story. Alim-Louis Benabid was one of the rare neurosurgeons performing thalamotomies.
Around the world?
Yeah, so around the world. There was some in the US, in Japan and Sweden. And so, but in France he was alone. And there was some indication for patients with severe tremor. And Benabid asked me, I need a neurologist to take care of these patients, first to confirm the indication, and second to continue to see the patients after surgery. And even during surgery, if you want to come in the operative room, you will be welcome. And this is an important point, and I think that this attitude of Benabid, everybody calls him Ben, so I will continue. Of Ben was something very important for me, because I told you that neurosurgery was a specialty that I hesitated. Yes, but to go in the operative room, I was very pleased at the time. Of course, my job was only to see the patients, to participate, to knew the best position inducing tremor. Patients were studied under local anesthesia, and stimulation was done just before lesioning to be sure not to induce severe side effects.
But you were much younger than Professor Benabid at that time, so he considered you already as a movement disorder specialist. How comes? What was your local role in neurology?
Yes, because when I came back from Paris, I decided to create a movement disorder unit, because and this was thanks to Pierre. Pierre gave me the time sufficient to be involved only in movement disorders, and this was very new at that time, especially in France. All neurologists should have been a general neurologist, so had a long background in general neurology.
Before?
Yes, but in '87 I decided to focus on movement disorders, and this was possible, and the advantage is to see a lot of patients, and we followed thousands of Parkinson patients. It was also the beginning of botulinum toxin,
yes,
and tremor patient, and all the major movement disorder diseases. So we were a center of reference and seeing a lot of patients.
So
And this was very important, I think, for the success, for the future success of DBS, that we manage Parkinsonian patients and tremor patients with depth, a deep thinking in the pathophysiology of all symptoms.
Okay, so not only the surgeon was sure the patient indeed had a PD or essential tremor, it was nicely evaluated.
Yes.
Okay.
Yes.
So that was the
And
time.
even at the time of thalamotomy, I saw many patients before the indications, and many patients came back at home with another treatment and very satisfied.
Yes.
I was pharmacologist.
Okay. So that was the time when deep brain stimulation, or DBS, in the thalamus, in the VIM began.
Yes.
How did that all start?
So the discovery was made by Ben in the OR only by testing two frequencies, 50 and 100 frequencies in patients under local anesthesia, and he noticed that only 100 hertz stopped stimulation, tremor, and not 50 hertz. So he decided to implant an electrode and not to perform the lesion. And he made a prolongation, and after he called me and, Pierre, now I have a patient. If you stimulate at 100 hertz, he stops shaking. Try to understand and to know if this favorable effect can last.
Okay, so that means the patient did not have a neurostimulator, he just had an electrode?
He had an electrode.
He came to neurological ward?
Yes, so he was in the movement disorder unit.
Okay.
And then I tried many things, with an external stimulator for animal use only. And it was possible to test any types of frequencies, pulse width, intensities, of course. Okay. So I try in these very first patients all the available electrical parameters. And
that's the explication of this curve that
yes,
in
the Lancet. So it was our paper in '91.
A logarithmic scale. I always had difficulties in understanding is how could you stimulate at 1,000 hertz?
Yes, because with this stimulator it was possible to choose any frequency. Of course, we were limited in the high frequencies because of the duration of the pulse. Yes, because over 3,000 hertz it was not possible to decrease lower, I think that 40 or 50 microseconds.
Okay, that explains why at 5,000
yes,
curve goes back up.
I don't know what it means to stimulate the brain at 3,000 hertz. And it seems that there is some loss of effect over 1,000. So 3 is 1,000, 2 is 100. But what was very important is this part of the curve.
Yes.
And so nothing occurs below 50 hertz.
Yes.
And in all patients it was the case. You can increase up to 10 milliamps if there is no side effects. The tremor is the same.
Okay.
And sometimes, as you induce paresthesias, tremor will increase because of perhaps increase in alertness.
Yes.
And over 50 hertz, there's a beginning of decrease in tremor. 60 hertz, 80 better, 100 even better. And over 100, generally, it's a plateau.
It's a plateau. Yes.
In some patients, it's even better at 180, for example, up to 200. Over 200, no improvement. But generally, the improvement occurred from 50 to 100 hertz. So it was called the high-frequency stimulation because it was in the region of 100.
Higher than used to be used in the OR before, or what is high?
No, in the OR, I don't know why, perhaps from Penfield. It was the use of 50 hertz always. I don't know why.
I think at high frequency there had been some epileptic fits, that's why.
Yes, that's perhaps. Okay. So with these patients, I stayed hours and hours studying. This is the intensity of
so this,
to stop tremor. This is tremor.
Well, this is one curve, one patient.
Yes, it's for
patient, and many.
It's for 4 patients and many trials of many frequencies.
Okay. And what about this one? So
it's exactly the same reasoning. The symptom and the increase,
which is tremor here,
and the electrical parameters.
Okay.
So highly variable symptoms can be tremor, but it can be also side effects. So I chose one parameter with the other constant, and I increased, and I look at the patient, and the patients told me, oh, I feel this, and I look at the tremor. And for this patient, for example, it was the study of the voltage. I chose 130 hertz because it was the effective frequency. So it was the study of the intensity, of the electrical intensity. So I increased progressively at 130 hertz and 60 microseconds as pulse widths. And we see that tremor progressively abated. And at 2 volts, no more tremor. But if I continue increasing, other symptoms increased. It was dysarthria, cerebellar dysmetria, for example, and it was incredible in these patients. It was patients severe tremor, Parkinson tremor. So we increased up at 2 volts. And perfect, everything perfect. I continue, and at from 2.8 volts, beginning of dysmetria, and at 4 volts, the patient was really dysmetric, like this. So but the meaning of this is very important, because at 2.8 volts, you have a deleterious effect on the cerebellar pathway. I thought the cerebellar thalamic pathway, and at 2 volts, you stop tremor. So you stop the oscillations associated with tremor, which pass through the same nucleus as the cerebellar outflow, the VIM nucleus.
To the cortex.
So it means that stimulation works by avoiding an abnormal oscillation, but you can also be deleterious on the function on the same path if you stimulate too high.
But let's come back to that first patient. So you had the patient on the ward. He did not have a stimulator.
So it was two to 3 weeks. And Ben said, oh, it's not possible to let an external connector for longer than 3 weeks because of the risk of infection.
I think that was really
generally, it's 2 days. And all the neurosurgeon was to remove the external connection. So this was up for 2 or 3 weeks. We had no infection in no of these patients who stayed weeks with external electrodes. So what to do? After 1 day, 2 days, it worked well. So I stimulate these patients with an external small stimulator, as for pain, you know, this type of stimulator. And it worked, it continued. So after 2 weeks of continuous stimulation, it still works as during. This was incredible. I think it was the great chance of DBS. You can stimulate the brain, and there is minimal tolerance, no or minimal tolerance. And you know now, then 25 years later, you stop the stimulator, and the patients begin trembling as before. So it was decided either to stop, to make the lesion, or to propose stimulation in the long term. And Benabid knew all the material for the treatment of intractable pain. And the electrode was the electrode for pain, and the stimulator was also for pain.
The material was there.
Yes, the material was there, and the first material I remember from Medtronic, this only manufacturer at that time. It was the Itral one, and the Itral one, the upper frequency limit was 130 hertz.
Okay, that's why.
And that's why we stimulated 130 hertz. But I'm sure that 125 or 110 hertz would be the same benefit. This was the explanation for the upper limits. And the second upper limit, 185, came from the Itral 2 stimulator.
It was the material that was on the market determined. Okay. So that was the situation with thalamic stimulation, but then things changed a lot. Then there came new targets, the subthalamic nucleus, the globus pallidus internus. How the stage was set, so you just had to start, everything was done, or was that different?
It was a great difference. For the thalamus, it was by serendipity to replace. So the was to decrease thalamotomy lesioning-induced side effects with the advantage of reversibility, of adjustability, of stimulation, a functional therapy instead of making a lesion. It was our first objective. But in the 90s, there was a great advancement in the neurosciences, and it was demonstrated that the output of the basal ganglia was overactive in response to dopaminergic nigrostriatal lesions. And this was really new. There's a lot of excellent teams which demonstrates this point. So in 90, there was the seminal paper by Bergman, Malone demonstrating that lesioning the subthalamic nucleus, which was overactive, in MPTP monkeys greatly improved Parkinsonism, almost disappearance of Parkinsonism. When we saw this, we had just demonstrated that 100 hertz high frequency stimulation of the thalamus, of the VIM, nucleus of the thalamus, had exactly the same effect of the lesion, the same site of the thalamus on tremor.
So the idea was in the
Yes, immediately when I read this paper in 90, we should put an electrode. Why not to lesion the STN? Because at that time, for the neurosurgeon, they was taught during a thalamotomy, don't go too deep, because there is the subthalamic nucleus and you will induce contralateral hemibalism.
A no-touch zone.
Yes, the subthalamic nucleus was known to be the site where any lesion can induce hemibalism. So don't go to the subthalamic nucleus. And at the same time, there was a paper in the movement disorder saying, it would be very interesting to inhibit lesion or high-frequency stimulation, but to inhibit the subthalamic nucleus. But we should learn a lot before going to patients.
Yes, well, actually.
So I remember at that time, I read excellent paper, incredible paper from anatomist Carpenter, Mettler in the 50s.
In the monkey.
They studied tens, I think 54 monkeys. Don't remember the number, but it's a paper in Journal of Comparative Neurology, perhaps 100 pages. And the clinical aspect of these monkeys were very well studied in relation with the anatomy of the lesion, the subthalamic nucleus. And the results were the following. If you lesion less than 20% of the subthalamic nucleus, you don't induce hemibalism.
Okay.
Second, if the lesion is outside the subthalamic nucleus, especially on the pallidal outflow tract, you will not have dyskinesias.
You had not seen that you can improve.
So our reasoning with Ben was that if we implant an electrode in the subthalamic nucleus, we will destroy, by the presence of the electrode, we will destroy less than 20%,
less than 20%, of course.
Except of the risk of bleeding, of course. And that's why we decided in '91 to stimulate using high frequency the subthalamic nucleus and the GPI. It was the resurgence of the pallidotomy.
You cannot go from the monkey to the human? Like that?
Absolutely. So we should demonstrate that high-frequency stimulation of the STN in MPTP monkeys had the same effect that lesioning, and this was done by in Bordeaux by Hamid Benazouz with the help of Jean Fégé, and he used exactly the same parameters as we used in the thalamus for tremor, and Ben Hamid was a member in his PhD defense. And Ben Hamid said, "Oh, now it was done in monkeys, we can go to humans."
So you had the argument even before it was published?
Yes. Yes, because his paper took a long time to be published. Yes. I don't understand why, but it was not accepted by, as many good papers was not accepted in many 1990. The paper by Bergman, by a guy, and we decided in '91 that it was interesting to stimulate the STN. In 1902, there was the experiment by Benazouz demonstrating that high-frequency stimulation in MPTP monkeys greatly improves Parkinsonism. So in '92, I wrote to the INSERM and the project.
Which is the French government?
Yes. The INSERM is the official agency for medical research in France. Yes. So it took a long time because of, I think that the referees thought, oh, they are a little foolish to go to the subthalamic nucleus.
So they blocked for a while.
Yes. But finally they agreed for, I remember, six patients only.
You had a go signal for six small series.
It was like a phase 1 study of safety.
Of course.
Safety.
Experimental surgery. Yeah.
And we began in January or February '93.
Okay.
The very first patients. So now it's a new story. The discovery of subthalamic nucleus stimulation and the effect not only on tremor, but on akinesia, rigidity, tremor, and in all the brain.
There was GPI also?
And during GPI, yes, but the very first patients we were a little disappointed with GPI. So our decision was to propose GPI stimulation in patients with very severe levodopa-induced dyskinesias and STN stimulation in patients with severe akinesia and rigidity. The very first patients were very difficult to find because I searched for patients with severe akinesia, and as you know, the patients with severe akinesia are those with the most severe levodopa-induced dyskinesias. But some patients are totally frozen when they are off, but with minimal dyskinesias.
Okay, so you had a lot of work at that time. Looking back today, what would you say was your most important contribution to the discovery, the evolution of deep brain stimulation, development of deep brain stimulation?
I think to have proposed the way to use stimulation, DBS, in patients. I spent hours making this type of curves, like in Stremer. I should quote Patricia Alim-Louis, who made the same work on STN stimulation, and what in my memory was very important were the first patients with bilateral STN stimulation. It was a story incredible. You know the story.
Can you tell us what were your best memories of?
Two things. Yes, these very first patients operated bilaterally. These patients was the first three patients were unilaterally operated because we thought that it was possible only with unilateral STN stimulation to improve both sides. And these patients told me, "Oh, it's very well your stimulation. Before, when I was off, I was tetraplegic. Now I'm hemiplegic, totally useless." So in this patient, we decided to stimulate the other side. It was 3 months later. And Patricia was responsible to switch on for the first time the second side. And you know Patricia Alim-Louis is shy, and she entered my office and told, Pierre, oh, he walks. Okay.
Calm down.
So I was in consultation at the outpatient clinic, and I moved to this patient and with Patricia, and the patient was perfect, like best on. And I said, Patricia, oh, you injected apomorphine. Yes. And she said, no. He works, no drug at all. So I switched the stimulator off and on, and you have the video. It was published in Movement Disorders. These patients totally off, tetraplegic, these severe patients, and you switch both stimulation and normal. Without tremor. It was only an akinetic, rigid type of Parkinsonism. And this was incredible because it was not possible to think that such a treatment could be efficient. As levodopa, as apomorphine, at the best of levodopa. It was incredible. So my second memory was when the David Marsden, the late David Marsden from Movement Disorders, said that it was something interesting. It was in Roma. I think it was my first oral presentation of the very first 6 patients on bilateral subthalamic nucleus stimulation, and I showed the videos. And after discussion, any question, and Marsden in the audience said, I would say one thing. In Parkinson's disease, there are 2 miracles. First, levodopa. The second, subthalamic nucleus stimulation. You know, when you are a young neurologist, and when the Pope tells this,
in Rome.
How? In Rome. So I think it was something very important for me, and it opened all the ways to continue this type of treatment.
Okay. Well, today you're not a young neurologist anymore. If today a young neurologist comes to see you and would like to have recommendations, you would like to enter the field of movement disorders, to get into translational research, what would be your recommendations for him today?
I think that he should have 2 qualities. First, to like patients, to like examining patients. I told you all the patients teach us meticulous examination of patients. And second, to be educated in basic neurosciences.
Especially in movement disorders, you can see.
Yes. That's why the examination is so important. And with stimulation, you influence all the brain. And you know that when the first patient become stimulated in the STN, become laughing, it was also something incredible. It could be another good memory. So, so a good clinician and a good neuroscientist during his career, I think that just when he, before the end of residency in neurology, he should make a break for 2 or 3 years and to go to one of the best laboratory in neurosciences and to,
really basic,
to learn, yes, basic. And after he will be educated for translational neurology to go back after to the clinics, and he, I think he will
to allow this transfer
be able,
bench
yes,
to bedside
yes,
and the other
to
way
be
around.
able to speak with basic neuroscientists.
Okay. While we are at the meeting of the Movement Disorder Society, has the MDS been influential in promoting, in
Yes.
helping?
Yes, always.
the
From
principles?
the start, the MDS was very interested in DBS and encouraged all the posters, and also they asked me to present the results. And Stan Fan was a great supporter, even not only the MDS but the Academy, American Academy of Neurology. From the start, perhaps from 89 or 90, he asked me to give a teaching course, the American Academy of Neurology. Was a president at that time.
Okay, thalamic stimulations.
Yes, thalamic and subthalamic nucleus. So the MDS greatly supported, always.
Okay. Well, I think we're coming close to the end of the interview. Do you have any further issue you would like to bring up?
Yeah, the importance of the multidisciplinary approach. When you make research on the brain, it's not only in movement disorder. You should be a good movement disorder doctor, but also open to behavior, to cognition, to any brain function. And then you will discover a lot of things.
And to surgeons.
Yes.
Okay.
Thank you.
Well, thank you very much. Thank you.
Thank you.